to request data from the epi, you could get, some kind of substantial data. I'm not sure if you saw that.
Yes, I did see that, and thank you so much. And I apologize if I did not follow up with a thank you for that info. And I'm going to be speaking to Barbara. So I just don't know, and maybe do you know usually the time frame in which you receive data back?
You mean when you put in the request?
Yeah.
Uh, it's not that long. Sometimes it depends on their, what they are dealing with at the moment, but it usually doesn't take that long. As soon as you put it in, yeah, the girl, I used to work at DPH, and so sometimes I'll just pick up a phone and call her, and she would just send it, but it usually shouldn't take that long.
Okay.
Yeah.
Perfect. Thank you.
Yeah.
All right. Looks like we're missing quite a few, so I'll just give it like a few more minutes. Maybe we'll get started at like 5 after.
Sure.
Is Jasmine back from her vacation?
Yes, she is. She had a little bit of family emergency, so I'm not sure if she's joining
Oh,
us, but
okay.
yeah.
Never like to hear that.
I know.
I'm talking away here. Karen just emailed and said that she is running late. Barbara Cass actually hoping she can jump on because she did provide me with the survey information. I'm just having a hard time understanding it, so it would be great if she can figure that out for us. Um, okay. Do one thing.
Hey, everyone.
Hi, Barbara.
Hi, Melissa. I said Michelle before, but I meant Melissa. Hi.
That's okay. I answered anything.
I'm sorry.
That's okay.
Melissa, I was trying to convert the home health hospice survey that we sent out, and I was trying to channel your skill set as I'm trying to navigate through office.com. Not successful,
It's
but I
crazy.
did send the links to Tony Ann.
Okay, great. I used to work with economists at some of the banks that we used to work with, and they would send me the craziest stuff. And sometimes I just have to recreate their entire platform because they're like, wow.
You know, and then sometimes you do a presentation and somebody would have copied the American flag, but copy of a copy of a copy of a copy. So by the time you get it, it's orange and white, not red and white. So interesting.
Okay, I don't want to hold everybody else up. We are missing some people. I think Karen is going to try and join at some point. Dr. Moss, unfortunately, had an emergency and is unable to join today, which I'm going to try and catch up with her at the end of this meeting, closer to 4 o'clock, so we can go over like where we are to date with the proposal and everything. Because I don't know what is wrong with my monitor here. I can see everybody and I know who you are because I know what you look like. I can't see any names. I can see Ross. Then I see Peter. Can you help me? I see REP, but I can't see anything after that.
You see REP? What do you mean by that? Can you expand
Like
a little?
there's a
Sorry.
representative on, but I can't see the
sorry.
name.
I think she's saying
Representative
Rep.
Nicole Claire Distria.
Claire Distria.
Yeah.
Oh, thank you so much for joining us. Okay, we're just gonna jump right into this. Now, have we by any chance, I don't know if Melissa or Peter were able to send out our attachment to the group?
I did not, but I'm happy to do that. I think Peter might have sent it out already.
Yes, I think
Yeah, it got sent out to
something.
Your slide deck. Is that what you're
Yes.
referring to, Tony? And I
Yes.
got it.
Okay. So I also had the opportunity to meet with Senator Anwar and Representative McCarthy Vahey on Friday. I saw them up at the legislative building, and we did talk about getting something to them with language in it as early in March as we could, which we're shooting for the first week. In that language, we will talk about needing an extension to, whatever we actually decide on to do is going to need much more work to actually, get it to come to fruition. So the language will be to be able to hold the bill in place, which they're asking to mandate, that the recommendation, be considered. But I think we have a lot of work to do. I think we have ideas of what this should look like, and it's like one versus the other, and we're going to need a little bit more help, I think, from the legislature to tell us which way is the more reasonable way to go. Because, we're looking at an overall program, although not changing palliative or hospice care, just putting it under a program for children in Connecticut and then deciding what level of care do they fit the criteria for, what those payments would look like, how many visits that would mean. So almost, although it would still be palliative and hospice, it would be determined by level of care. We're also looking for funding, either funding through the state like Massachusetts does it, which would be like a hub and spoke kind of program that would be run at the state level. And then the state would actually deploy the cases to the certain agencies that do it in the geographic area. So there's two things we kind of have on the table that we will talk more about before we actually present it. But what I wanted to do today when I see Barbara on here is that survey is great. Can you just help me understand it a little bit? Because I see the numbers and then there was like one or two comments, but can you talk us through the survey?
Absolutely. Does it help, Tony Ann, if I share my screen? And actually, so office.com has a presenter's view, which I spent an inordinate amount of time trying to learn how to transfer that to something I could share with you, and I was not successful. But if it's helpful, I will share my screen and go through the presenter's version of it, which gives better clarity as to what we asked and does do bar graphs. So let me pull that up. While I
Okay,
pull
great.
that up, if you want to either wait or it'll only take me a second.
Yeah, I just want to add, I will add to everybody while Barbara pulls that up. It has been extremely difficult to get data. It has been like really hard. I have worked with Melissa and we have spent hours with the Yale Law Group who are doing their white paper on pediatric palliative and hospice care in Connecticut. They have been phenomenal in sharing data. But there is a lot of data that they have not been able to get either. I've also spoken to Eileen O'Shea, who has been able to share some data, and Elizabeth Broden. So we have gotten some data, but up to the point of last week, as of Thursday, we had very little data. So we have a lot of experience around the table, but we need the numbers to back us up here. And that's where we're kind of falling short. I think after we go through, I have the draft of the white paper from Yale Law. And I also, Melissa and I have been going over Eileen O'Shea's call to action, which was in 2017. So we're slowly getting through the data part of it, but that has slowed us down a little bit. So I just wanted to throw that in there.
So whenever you're ready, Tony Ann, I can share my screen.
Go for it.
Okay. So we had 26 responses, and I have spent some time as recent as, earlier today, doing some personal calling to home care agencies to encourage them to respond. So I'm anticipating that we should get 5 or 6 more responses, and I will continue, go through my list and make calls to them. And Tracy, I don't know if you can send out a reminder to your membership and ask them if they haven't seen the survey. I'm happy to send it out to them, or anything that I can do to be helpful. We never get 100% of a response, but at this point we're at 26 responses and we have 88, I think, licensed home care agencies. So first question, does your home care agency provide hospice and the provision of services approved by the Department of Health? 53% said yes, 46% said no. And this is, I think, a critical question. Does your licensed home healthcare agency provide pediatric services? And of that 26, 76% said no, 23% said yes. So it is a small universe of agencies that currently can provide the service. And then we had the question response was yes. It was medically complex care. And let me see if I can, 84%. Oh, wait a minute. I should have practiced. So this 23% can provide medically complex care. And let me look for my paper version here. And the other percent is acute pediatric care.
Acute pediatric care?
Pediatric hospice care. So the response, acute pediatric care. So I think those are the all point, Tracy. They provide strictly pediatric services.
I would put them under the pediatric complex care. That's why I'm not sure what that is.
I can drill that down with the respondents and get more information on that. So you know what I'm going to do? This presentation, this view is not working. So here's where we can review the responses. It'll be better. Can everyone see my screen? I changed screens and presentations.
Yeah, can you make it a little bigger or no?
I think I can. How's that?
Better.
Okay. So here's if the response in question 4 was yes, do you provide the following? And so the 18, it was they don't provide it. And then 6 provide medically complex care. And the other 2, it's acute pediatric. And the following services, 1 provided pediatric palliative care, 3 pediatric hospice. Again, 22 of those 26 agencies do not provide pediatric services. You know, Tony Ann, when we spoke about the survey, this was a question that was important to you. And when was the last time you provided pediatric palliative care services? So here we can look at that. 2023, and then 1 respondent indicated they currently have children that are on service under the palliative care umbrella.
I see those are all anonymous. Are you able with
No,
any
I
of
have-
these responses?
Yes, I do have, that's how forms.com does pull it up, but I have the
Okay.
respondents. So we can reach out to them.
Oops.
And here's
Yes.
how many cases of pediatric palliative care or pediatric hospice care did your agency provide in calendar year 2024? Again, small universe.
I'm guessing the 2 that responded 5 to 10, it's regional and Yale.
Mhm.
I'm not sure
You
who
just-
responded on our behalf, but we probably in that 5 to 10 in the course of
Oh,
a
you
year.
would be? Okay.
I did reach out to your agency and they are going to respond.
I apologize if we didn't. I'm sorry
Nope.
about that.
I spoke to your leadership there. I understood completely what the gap was related to. And I do want to note that there were some agencies that we didn't have the best contact information for them and they didn't receive the survey. So in my conversations with them, they were very happy with the outreach. And then when was the last time you provided pediatric hospice care? We talked about that one. Do you have the capacity to provide pediatric palliative care or hospice services today? And 4 responded yes. And then this question, what are the greatest challenges?
Can you scroll back so we see it in totality a little bit?
Yes.
I think just diminish your screen just a tad bit. Oh,
Which thing do you want to see, Melissa? The one,
slide 11.
Melissa, I can send this to you. I will send,
Okay,
I will have you the collaborator. So you'll be able to see everything here that,
Okay.
and your IT skill set is far better than mine.
okay. I mean, I can export some of this stuff so it's usable in a format that just a single slide, so.
And the greatest challenges, 3 people responded staffing resources. Another response was volume is low.
Hmm.
And those were the 2 responses. And let's see what they answered here. So reimbursement is one of the challenges that this particular agency brought up. And then finding qualified pediatric nurses is difficult, which we have identified. We have seen through the certifying associations that the Connecticut numbers are low, I think, and I'm going from memory, I think our Connecticut numbers for certified pediatric hospice nurses, I know it's less than 20, and I think it's approximately 14. So it's a very low number, and that demonstrates, Tony Ann, the concept that you had regarding creating a center of excellence in education.
Right. Yeah, so I mean,
I will stop sharing.
Yeah, no, this is great to actually see, and it confirms, things for us, which is amazing. And it's like the same thing we see. And please, somebody tell me, Melissa, you'll keep me honest here. Did I already share Carolyn Torella's story with this group?
I don't think you did,
Okay.
because it just happened last week.
So I got a phone call last week from a mother whose son died in 2021. There was an incident at birth that caused brain injury, and his prognosis was 50 to 60 years. So he was, very limited, couldn't walk, didn't speak, could definitely see and hear. They thought he was deaf for a while, but then they realized he wasn't. Could smile, was, very advanced that way, but no speaking and, walking. He was fed by, a feeding tube. But at 15 years old, he ended up falling out of bed and breaking his jaw. And titanium plate had to be put in his jaw that then became infected. And then ultimately, he died from the infection in his jaw. And when she called me, she said, I was like, oh my God, she wants to call me from 2021. I don't know, this doesn't sound good. But he was only on our service for 3 days. And she wanted to let me know that she's finally at a point where she can talk about him and what happened. But she also wanted to share with me that she felt it was a great injustice to her son that he was only able to be on hospice the last 3 days of his life. And she said the care was great. They got in touch with us on the 27th of July. We admitted him on the 28th, and he died on the 30th. And she said here were her barriers to getting more care for her son. She said, number one, she lives in Cheshire. No one recommended regional hospice. She didn't even know we did pediatric care. No one would even have the conversation with her that there wasn't more to do and that her son needed hospice care at that point. She said none of the clinicians wanted to have that conversation with her. And then, unfortunately, she was told by one of the hospices in Connecticut that they would take care of him at end of life. And when she called during the time, what they thought was at least 2 weeks before his death, they were told, really, we don't take pediatrics, so we're not going to take him. A nun, she said she's trying to remember the nun's name. She hasn't gotten it back to me, but a nun had heard of regional hospice. The mother, actually called us inquiring on the 27th, and we then admitted her son the next day. So she said a couple of things that she found, and she would love to talk to any group or get the word out there or, whatever. She found that there's not enough hospices doing pediatric hospice, as we know. These are things that we're not, dumb to for sure. If they do hospice, no one knows about them. If they do pediatric hospice, there's not a good, general consensus that there's even hospices out there doing pediatrics. And she said, worse than anything, she couldn't get a clinician who would actually talk to her that her son was dying from this infection and was not going to survive. And until, she said he got to a point where he was unresponsive, did she start to realize something's happening here, and my son needs end of life care. So it was kind of good to hear from her that the things that we're seeing, because we know how many sick kids there are in the state of Connecticut, and we know how few are actually receiving palliative or hospice care.
Antonia, one of the
Go
things
ahead.
you mentioned to me is the fact that when you had reached out to offer bereavement services, her response was, I don't know who you are.
Right.
And
Right.
she had wished you had been there way earlier.
Yes. And that was, I keep forgetting that, Melissa. I have to keep that like in the forefront of my mind. I said to her, I go, oh, so I know this was back in 2021, but did you take advantage of the bereavement services that we provide for the year that could, because he was a twin. So he has a surviving twin who is, really still struggling. And he has two other siblings. And I said, did you take advantage of the bereavement? She said, I didn't know you. She's like, your nurses were great. The social worker was wonderful, but I didn't know you enough to now put my family in your hands for bereavement. So we know things need to happen sooner. We know clinicians need to have better discussions than what is happening. We know all of these things. And the question is, do we look at a program which Yale Law is actually, that's part of their suggestion or recommendation is, do you look at, and for me, it's not changing palliative or hospice care because, that's national. But how do we put them under an umbrella that would be, like if it was champion care for children, and palliative and hospice are under there, and we assess at different times when the child would need increased level of care and change from a palliative approach to a hospice approach. Help with the funding. The funding should be able to help with marketing and education, which is key. And also the education for a pool of people to actually have it in the curriculum in a nursing program that nurses are learning about palliative, hospice, end of life with pediatrics or adults, and actually doing clinicals for those areas. So those are the kind of things that we're aiming at here. I know that if you all have received the potential proposal or the language around it, we can also send more out on the hub and spoke kind of approach from Massachusetts. Do we have that in there, Melissa?
We have a page that shows a center with the child as the center, a child-centric approach. So yeah.
Right. And that one, as you all know, is, completely funded by the state, and they have one central repository that runs at a state level, and then the state deploys the cases to the agencies that are part of it. They have 10 agencies in Connecticut that participate. So I'm just trying to figure out, as we wait for more data, as I, need to speak to Dr. Moss this afternoon, is there anything anybody wants to bring up at this meeting that we need to look at, that we haven't looked at, that we should be considering, that we're not considering? I just want to open the floor to whoever might have comments or insight. Okay, I don't know whose hand went up first, but I'm going to say Tracy.
Was it? I think it was Barbara, but I'll go. So the data that Barbara put up on the survey and the percentage of complex care pediatric cases, many of those cases fall into that serious illness category. And I'm guessing the case that you talked about was one of those cases. And I remember that case well because Sister Catherine Mary contacted me and I said, call regional. So
Well, thank you.
didn't know there was only 3 days, but not unusual.
Right.
Not unusual, as you all know. And not unusual that the response of Why would I look for bereavement services from you when I didn't even get to know you? You know, that's one of the struggles of last minute hospice care.
Right.
So, when I look at all of that, the complex care, that percent 23, and it's really 30% because the other percent was acute peds. Most of their cases, 90% plus, are Medicaid funded and Medicaid only funded. And we cannot currently compete with out-of-state rates around our borders. So
I read your article.
that's one of the things, thanks, Karen. That is one of the huge challenges in getting funding and trying to make sure it's putting the cart before the horse sometimes. We know we need pediatric hospice and palliative care in Connecticut. We know that. But at the same time, if those are the agencies that already have some expertise in caring for the pediatric population, and they still can't get enough funds to pay their staff enough to retain them and recruit new, how are we going to get funding to level the field to have enough staff and then to add to it to be able to train for the specialty of end of life and serious illness care? So it's a huge challenge and very serious. I know you need to put forward in the report your recommendations, but I would strongly recommend that funding has to be part of it.
Absolutely.
And it can't be a standalone to Connecticut, what they want to reimburse in Connecticut. They really have to look at the rates in all bordering areas if they want to create any level. I don't even want to say robust level. I want to say any level of adequate.
Okay. Oh, you got frozen on adequate. Oh, and I think,
Pediatric and palliative hospice care.
okay.
I'm done. Sorry.
And so heard, because right, funding is the key. No funding, none of this moves forward. Nothing moves forward. And I actually said on Friday when I sat with, Senator Anwar, I said, I have to tell you that we're at a point where if I sit here with you as a businesswoman, I'm telling you the numbers don't work. I'm sitting here as the CEO of a nonprofit, and I'm telling you we're doing it, and we've been doing it for 15 years, but I don't know how much longer we can do it without funding. So, funding is key. So totally heard, and that is absolutely going in
Yeah,
there.
but the reality of your business and most of the hospice providers in Connecticut, it's 98% Medicare.
Right.
So you can take cases here and there and lose money on them because you're able to manage. But those agencies that I was talking about, they're more like 98% Medicaid.
Right.
So adding specialty services is not a good business model, not one that can
Right. How
begin
can
to be
you
sustained.
how can you do it? It's unsustainable.
Mm.
Barb.
So I just have two comments or follow-ups. And one is, Tony Ann, can I connect with you offline? I want to the extent possible, see if I can help with this data issue. I did have outreach with Vital Statistics, and there may be some data that we collect in the background, but it would be a special request. And I want to make sure that whatever request I give to Vital Statistics is exactly what you are looking for to include in the report. I don't want to make any assumptions.
I would love that. And I think Melissa has a good handle too on what we have and what we
Okay.
need. So maybe we can coordinate that. I can send an email out and we can coordinate for the three of us to go over that.
Perfect. I'm happy to try to facilitate that. And then
Does it make sense to also look at what's the group, the rare disease? I think that,
Leslie Bennett is the facilitator of that group.
yeah,
The Rare,
I mean
Rare
that,
Disease Council.
yeah, that may have some info for you.
We actually, let me poke at that because we help support that Rare Disease Advisory Council. And let me check with one of my contacts here to see if there is any data available. So I'll look at both of those pathways, but let me get a clear pathway of what you're looking for.
Okay.
Excellent.
And then my second comment or question is, I hear the story, Tony Ann, that you report with this lived experience with this family and this 15-year-old. And I don't think I have a good handle on or a good understanding of what happens to a child. And again, never having, thankfully, lived this experience, I don't have a good understanding or visibility on what happens when a child is diagnosed with a life-limiting disease and may need other support services. And the reason I bring this up is, number one, do pediatricians have good visibility on what services are out there? And is there an opportunity, and again, based on successes we've seen with other programs and building toolkits, I know education has toolkits that they share. We have just built a toolkit in one of our other programs at DPH that offer support to providers so that it gives them a roadmap as to what services or supports are out there. And is this an opportunity for this group to maybe pause and look at building or developing a resource that could help pediatricians, that would help patients, children, families?
You're 100% spot on. I mean, what are the pathways that these, physicians use? And with having so many kids, right, in the state of Connecticut that do have life-limiting illnesses, diseases, or, injuries, things like that, I'm not really sure of the pathways or how most physicians actually respond to something like that. I know where our referrals come through, and most of the referrals we get have a palliative care team. I have no individual physicians that really, in the past 5 years anyway, that have actually referred a child here. It's either been a palliative care team, a family. I have, of course, like through Connecticut Children's and Yale, we get, referrals that way. I get referrals from hospices in New York whose families live in Connecticut. And New York seems to kind of have this rhythm that, they're aware when they have a child in their NICU, mostly Montefiore. They have a child in their NICU. The child is not going to sustain life. The family lives in Connecticut. We get the referral. It seems like a well-oiled machine. And I don't know, Karen, if you could comment on how you see the pathway to referrals and what you see from clinicians' perspective, because I don't have much more on that topic.
I don't have a lot either. I know, it's not like everybody's, from my or our experience, it's been, they're searching, and it's either through a connection with Tracy or now, through the Children's Hospital. They know that we do provide this. So we actually had an employee of the health system who, through the grapevine, heard something about us maybe doing pediatrics. So was advocating and got their child on. So yeah, there's no real mainstream hey, I want pediatric hospice in Connecticut. I'll go on the internet and find out who it is. There's not a lot of that, which it definitely should be a recommendation.
So if
Yeah,
I might just
Tony,
jump in, I'm sorry, go ahead.
No, I apologize for that.
Yeah.
It's Ross Albert. I was going to say, I think thankfully the pediatric palliative providers from the hospitals frequently know who they can turn to. So I would say at Hartford, probably our most common mechanism of connection is that Dr. Moss, Dr. Massaro know that they've got a child who's in one of our regions and they reach out directly. And so I think so much of it, like you said, it's word of mouth in that very local connection as opposed to a true program or a resource.
Right. And I was coming to you next, Ross, because I knew you were going to have input on that. And I totally agree, because that's where my resources come. They come from Kristen at Yale, Dr. Massaro, Dr. Moss at Connecticut Children's, and then outside of Connecticut, mostly for the referrals.
I think one of the things in putting together a single framework is proposing a pilot during which time we're going to build out all of these things. Right now, we don't have the luxury of time to provide all the answers, and there's a huge amount of information we know, but there's also a lot of unknowns. So one of the thoughts is, let's take the time, if we can get approval to move forward with a pilot, to mine the data that Barbara would be collecting to get best practices from all the different agencies and organizations that you lead and are part of, so that we can come up with a comprehensive footprint to go forward.
We did do a pilot with MOLST, and Tracy will remember this because Tracy is one of the pioneers for MOLST. And we had very successful outcomes as to it informed decision-making for a statewide MOLST. So we have that experience already.
It'd be great to hear what your results were and what, how you went through that process to understand, what the success elements were and where you felt you could, redirect.
Yeah, and that would be good information to have, I think. And believe me, I'm not saying like, one may have been easier than the other, but the most may have been, when I look at it from like a whole like program for palliative and hospice care, this might be a bigger gorilla. But what I would like to know too is, even for that, like, what was your time frame of the pilot? Like, how long did you spend piloting? Did you set a time frame that you'd say, okay, we'll do this a certain amount of time, and then another, a recommendation goes out?
I can look at that, but Tracy, I joined MOLST in 2018 or 2019. I can look at that. I can also connect with the person but Tracy, you were there in the very
but I don't remember the details, and I really think it's got to be documented so you'd be able to see exactly how it was done. But I'm not so sure there's transference over to this group, and I also think in the essence of time that you already recognize that both Tony and Karen and Ross do provide this level of care, and I think to me, that's kind of a pilot in and of itself, where we've already listed the challenges, the need, and the marketing piece, word of mouth versus actually having a plan. I don't know that a pilot it's just going to extend the time down the road. It's going to kick it down the road a little longer. I just think listing the challenges, listing the opportunities, and putting something forward is really what needs to happen. I don't know how Ross and Karen and Tony Ann feel, but I've heard many of the challenges very clearly listed.
Right.
I don't think a pilot is going to give us wow moments.
Right. I think I agree with you on that. Like, what we would be piloting something to find the same answers that we have now. Like, would we pilot more like, okay, what would a center of excellence look like for, training and things like that? Because all of these, unfortunately, it's like what you said before, Tracy, what comes first? you know, the chicken or the egg? Do we train the staff and then go after, you know, patients? Do you go after, like, you don't know what to do first, but the key would be that we need the funding. And I think that has to go into the meat of the proposal. None of this happens without funding. Like, that's a key. And I think if all of our experiences, Ross, Karen, myself, I think that would be a good starting point to say, here's our experiences. We have no means of, no like main place that families, physicians, anybody can go to learn what next steps are. And does that include more training, clinician training, like, you know, lots of things to think about from that perspective. I think what I'd like to do is just touch base with Dr. Moss this afternoon. Melissa, if you and I, because there's a lot of work going on in the background that I kind of just keep presenting to you all. So I want to maybe take this away as, so let's just say we did a pilot, right? Regional Yale and Hartford did a pilot. We've been doing pediatric hospice for how many years? These are the things we found. These are the recommendations that we need to put forth. We're recommending either it has to be a complete state funded, program. And without it, this goes nowhere. I mean, basically is my thoughts. Does anybody else have any other thing that they think can help this without funding being part of it? Yeah. Okay, so what I'd like to do then, since I said I'd only keep you 45 minutes today, is work a little bit more on the data. Barb, I'll catch up with you through email, you and Melissa, and we can see if we can get more so we just have numbers behind. I mean, I would have my own numbers. I'm sure Yale has their numbers and Hartford's. I don't know. It's much easier for me to share my data. I understand that, but if we can share our own, we can show, we have this many kids in Connecticut that could benefit from palliative care and hospice, and this many was on last year, what we've even serviced ourselves. And then add more to the proposal, Melissa, and then get it out to everybody before we actually won't share the slide deck anymore. We'll share the actual paper, the actual proposal, and then we'll go from there.
Tony, and given your example before of the 15-year-old and the length of stay issue, if they were actually on hospice, does it make sense for you to not just list the numbers, the service areas perhaps, but also the average length of stay, both median and mean?
Absolutely.
And then challenges, if you're gonna talk about the challenges of bereavement and grief services, that you might be able to tie that together.
Right. Boy, that's why they pay you the big bucks. You can pull this stuff right in. Yeah. I think length of stay is key, right?
It always is.
Absolutely. Geographic. Okay. Okay.
And then Barbara, the survey that you did, can I possibly get the names of the agencies that responded and send me another? I mean, I believe after our last meeting, I sent out another reminder to people and said, even if you don't provide any hospice services, please respond to this survey.
And I did get a little uptick. So thank you for that. I have checked off who, and I'm going to continue to call because I do have, once you make that person-to-person connection and someone tells you they will do it, they do it. And often when you send blast faxes to larger organizations, it's not unusual for them to be sent to 16 different people. It's not me, not me, not me. So that phone call is helping. It's just, it's going to take me some time to get to all 60 that haven't done it yet. So, but I'm going to move on. I'm going to keep moving.
So Tony Ann, in terms of reverting data, since we talk about turning over this report to the assembly members sometime next week, maybe by the end of the week, do we have like a week and a half window on getting all this to synthesize it and pull it together? And how realistic is that, Barbara, for you to be able to turn that around and not to push it all on you,
I
but
think, you know, what the senator told me was, I need language, is what he said. I
Okay.
need language just for a placeholder.
Okay.
And in the language, it would also say this will, you know, entail longer, you know, an extension of time, whatever, but he just wants some kind of language to hold the place.
Okay.
Okay, anyone else? And we'll send this stuff out to you all so that you can comment on it, and we'll send not the slide deck. We're going to just start sending out the written recommendations.
It's
And
not as pretty to read.
it's not
just
as pretty
warning.
to read, but it's, you know, it's what's going to be going. So thank you all so much, and we'll work behind the scenes as quickly as possible to get you something in short order.
Okay.
Thank you, everybody.